So hi, everybody. Thanks for being here. I'm Terry Redding, the comms lead for Momentum Integrated Health Resilience. We'll start off today with our project director, Dr. George Hanna, who will be giving us a welcome and a few words about Momentum. So George.
Thank you, Terry. Good morning, good afternoon, good evening, everyone. Thank you for joining our webinar today. I want to give a quick highlights on Momentum Integrated Health Resilience, which is a part of a suite of innovative awards funded by USAID to holistically strengthen quality, family planning, reproductive health.
You're a little far from the mic, George. You're too far from the mic.
To improve the quality of maternal newborn health, child health, and in partner countries around the world. More than half of maternal and child deaths occur in countries affected by conflicts, disasters, weak governance and institutions, population displacement, and other acute and chronic crises. In these settings, increased illness and death results from disruption of basic health services and systems, from family planning and immunization to service delivery and supply chain. The project focuses on increased health resilience capacities at individuals, households, communities, and health systems to reduce chronic vulnerabilities and promote more inclusive health development by addressing risks and respond to shocks and stresses, ensuring continuity of family planning, reproductive health, maternal, newborn, child health services. We work together alongside local organizations, governments, humanitarian and development partners in these fragile settings. So the project works to accelerate the reduction of maternal, newborn, and child illness and death by increasing the capacity of partners, country institutions, and local organizations, including new and underutilized partners, to introduce, deliver, and scale up and sustain the use of evidence-based quality interventions. Momentum also integrated health resilience contribute to global learning to strengthen maternal and child health, family planning, and reproductive service delivery and resilience. We also increase the availability and use of resilience metrics and analytics to better understand and adapt to the complex pathway involved in improving maternal and child health outcomes. We support layering, sequencing, and integration of humanitarian and development programming across different sectors to improve health outcomes. Also, we use tailored approaches and tools to match the needs of Momentum specific contexts in each country. And the tool to be presented today is an example of these adaptations to South Sudan context. Thank you, and wish you to enjoy the webinar today. Back to you, Ted.
Great, thank you, George. And just a couple of housekeeping items, folks, before we get going here. This session is going to be recorded and posted to the Momentum website. So this will be a public presentation. Time is short here, so we're not going to be able to address specific questions, but again, just put your questions on an ongoing basis over in the chat, and then when we get to the Q&A, we will address those. At that time, if you have a comment that you want to make or a larger question, you can raise your hand during the Q&A, and we can enable you to come off of mute and pose your question. There's also going to be an evaluation form at the end. It would really be helpful for us if you followed the link to the evaluation during the Q&A and answered a few brief questions. Our speakers will be coming on and turning on their cameras if bandwidth allows. I believe Kirk's having a little bit of a problem with his camera, but we'll check on that. And in the background, our good friend Chris Lindahl, who's our knowledge management lead, going to be monitoring and keeping us going in that sense. So if you have questions about any connectivity, please just also put those in the chat. Hopefully we can follow up those. I wanted to turn over to Kirk Dearden, who is our nutrition and wash lead for Momentum Integrated Health Resilience and is going to be sort of our master of ceremonies. Kirk?
Great, thanks, Terry. We are very excited to have you here and hope you will enjoy the webinar.
Next slide, yeah.
Next slide. Just by way of background, in the summer of 2021, we began working with the government of South Sudan and other implementing partners within Sudan to adapt the MAMI care pathway to local contexts, and then to document lessons learned. Next slide, please. So today's webinar will focus on useful learnings that we've had to date as we prepare to adapt the care pathway to distinct local contexts within South Sudan. As everyone knows, work in global health often takes longer than expected. And while we're not as far along with this activity as we had hoped, we've made good progress, and we have already identified several important lessons that can be used as the care pathway is adapted in other settings, as well as some research questions that we feel can be pursued. So as part of this webinar, we're seeking to understand MAMI and the care pathway. We want to discuss how to integrate the care pathway into overall MNCH services. We want to relate how Momentum, Integrated Health Resilience Project, MER, will adapt the care pathway in South Sudan, including operations research. And then we will also summarize to date any future opportunities as well as progress. So let's take a look at the agenda. Next slide, please. As Terry said, I'm Dr. Kirk Dearden, and I am the team lead for Nutrition and WASH on the Momentum project. And my co-presenters are Dr. Hedwig de Koning. She is our MAMI consultant and has been with us from day one. And she works at the University of Ghent in Belgium. She's a global health and system expert and has specific expertise in severe malnutrition and low-income countries. Mary Pony Jackson is the maternal and newborn health advisor for MER in South Sudan. She has specific expertise in comprehensive emergency obstetrics and newborn care, both in development and humanitarian settings. So our agenda today will focus on the MAMI care pathway, its history, importance, and we will provide a description of it, Momentum's MAMI work in South Sudan, and learnings and adaptations thus far. And as Terry has mentioned, we will have a Q&A and webinar evaluation shortly after the presentation. So now let's move on to Hedwig. Hedwig, I think you're muted.
Thank you. Good start, bad start. Anyway, greetings to all. My name is Hedwig, and I will cover in this session the history and importance of the MAMI care pathway and explain how it operates. Next. So MAMI stands for the Management of Small and Nutritionally at-Risk Infants under 6 months and their mothers. And the MAMI approach was created in response to the high numbers of infants who fail to survive and thrive due to a lack of nutrition or health services equipped to support them. The MAMI care pathway package consists of implementation guidance for healthcare providers to target and care for at-risk infants and their mothers tailored to their needs. It is the result of a collaborative effort of experts working together who are members of the MAMI Global Network that is co-led by the Emergency Nutrition Network and the London School of Hygiene and Tropical Medicine. Next. The MAMI Care Pathway version 3 builds on a broad range of learning from accumulated evidence and experience implementing earlier versions of outpatient care approaches for infants. Building the evidence started already in 2007, and earlier versions were available in 2015 and 18. Its development was supported by the WHO Severe Acute Malnutrition Guidelines published in 2013 that for the first time recommended that infants under 6 months with uncomplicated severe acute malnutrition can be treated as outpatients. To translate this recommendation into practical guidance, an integrated The care pathway approach was used, modeled on the IMNCI approach to facilitate integration and to complement existing national guidelines. It is currently being implemented as a research study or at small scale in various sites in Africa and Asia. Next slide. Some risks related to the infant and mother are listed here that evidence found to impact on infant growth. There are many factors that put the infant at increased risk of morbidity, mortality, or suboptimal development in comparison to their well-grown peer. And some of these risks are directly related to the mother. Therefore, the MAMI care pathway uses a broad set of criteria to define these small and nutritionally at-risk infant and their mother. And these may differ depending on the context. Next slide. Justifying the importance of strengthening the MAMI care pathway is not difficult. We know that globally, maternal and child undernutrition remains high, and progress in reducing child wasting and low birth weight remains unacceptably slow. But when it comes to figures for estimating the burden, we may run into difficulties because infants under 6 months are rarely targeted for anthropometry in prevalence surveys. As well, the expanded criteria of being at risk in the MAMI approach include overlapping conditions that may be present in one infant. But what we do know from evidence is that about 20% of infants in low-income countries has a low birth weight. Also, in countries with high prevalence of severe acute malnutrition in children under 5, the proportion or the burden in infants under 6 months is also high. And a recent study on a large data set from low and middle income countries confirmed these findings and suggested that about 1 in 5 infants under 6 months is small or nutritionally at risk. Next slide. While already major efforts are ongoing to prevent and treat maternal, infant, and young child undernutrition, significant improvements in the outcomes of the small and nutritionally at-risk infants are much needed, not to miss early and later life opportunities, and for achieving the Sustainable Development Goals. Next. The first 6 months of the infant's life is a period in which the health and well-being of the mother-infant pair, or dyad, as we call it as well, is often threatened by common health conditions or difficult situations that may have been prevented and or acted upon early, that may have consequences difficult to bear or recover from. And the MAMI approach aims to address these missed opportunities. Next. Therefore, the MAMI care pathway puts the mother-infant dyad at the center of comprehensive person-centered care. It doesn't just focus on nutritional status of the infant, but also his or her health condition. And as mentioned already, it considers the health and nutritional status of the mother, including her mental health, knowing how much this may affect care and feeding practices for her infant. How then the MAMI care pathway will be implemented depends on the context it operates in. Let us now look at the MAMI care pathway in more detail to understand well the approach. Next slide. This is a busy figure that displays the MAMI care pathway. I'll walk you through the basics, so please bear with me. The red infant in the lower left bottom of the figure is at high risk. The yellow one is at moderate risk, and the green one is at low risk. The purple line at the bottom shows the steps of the care pathway the infant and mother will follow from being screened, assessed, classified, or diagnosed, next to being managed, treated, monitored, until the infant reaches 6 months of age, when their outcome is being reviewed and when it's decided if further referral is needed to supportive, preventive, or curative care. At the center of the figure, you see a broken green, yellow, and red health services pyramid. The green rectangle at the bottom stands for routine preventive health and nutrition care at a community level, where the care pathway will refer low-risk infants. The yellow rectangle in the middle stands for MAMI outpatient care, where moderate risk infants are referred to. The red triangle at the top stands for MAMI hospital care, where high-risk infants will be referred to. If we now move to the blue vertical rectangle on the left side of the figure, above the purple line indicating screen, this shows that at any point of contact with the healthcare, whether in the community or at primary or secondary care, a rapid screening may be done, depending on the skills and capacity of the healthcare worker present. That may already identify low and high risk infants that may be referred up to or down to the appropriate care. But at a facility level with a MAMI service site, when a MAMI-related risk is detected during the rapid screening, a thorough assessment is being done to decide where the infant and mother will be enrolled and further followed and get tailored treatment according to the specific needs. And for that, see the blue horizontal rectangle in the middle that shows the core care pathway of moderate risk infants and mothers at the primary care level who will be following the MAMI services in outpatient care at the primary care level asset. In the middle of the figure, we see vertical movement between the levels of care, shown in the pyramid. Moderate risk infants may move up to a high risk level, thus be referred to hospital when their condition worsens, and move back down to moderate risk level when their condition improves, to continue being followed in primary care. A similar movement for low risk infants exists in case their condition deteriorates. And that you see that there is a yellow arrow indicating movement from the green rectangle to the yellow one. If you are familiar with community-based management of acute malnutrition for children 6 to 59 months, you see many similarities. But very specific for MAMI is that once the infant mother diet fall into the moderate or high risk category, they will stay enrolled until the infant reaches 6 months of age. Other is that the nutritional and health status of the mother, of the infant, is integral part of the risk classification of the infant. So therefore, it addresses the infant mother as an inseparable pair. Whether the MAMI care pathway includes all of the health services shown will depend on which healthcare services are effectively in place in the context we work. But its main focus is on activating the yellow pathway at primary care and establishing strong links with preventive community and curative hospital care. Not to forget that all along, the active community involvement for early detection and referral is strengthened. I hope this was clear for you. Now, next slide. This brings us to who is responsible for what activities and where. How to integrate the MAMI activities into existing services and their operations, not duplicating, but further strengthening the existing, and these decisions will differ for each country. Therefore, when introducing the MAMI care pathway in a new setting, it is useful to first analyze the national policies and guidelines, map existing healthcare and nutrition services, including knowing the roles and responsibilities of the various health actors. This exercise is good to do at a national level, involving key stakeholders, to then refine and adapt it at the MAMI service sites. The colored map on the right is an example of a useful resource from the package that assists in these discussions and decisions. Next. So my last slide brings us back to the MAMI care package, the MAMI care pathway package that bundles generic resources for use in country adaptations, training, and implementation. It is available online. And how the Momentum project will adapt and use this in the South Sudan context, my colleague Mary will cover in the next session. And I thank you for your attention.
Back to you, Terry.
Let's go to the next slide. And Mary, if you want to come off mute and turn your video, and please get started. Thank you.
Mary, you have to enable your mic. We can't hear you yet. And the camera, you're welcome to open it too if you want.
Hi, everyone. Greeting to everyone. I'm called Mary Pony, and in this session, we'll describe how the MAMI care pathway will be adapted to the South Sudan context in a pilot study. Next. The piloting of MAMI care pathway is conceived as operation research in which a prospective cohort of at-risk infants mothers diets are followed for a 12-month period using a mixed method of approach, including quantitative and qualitative data collections and learning. It was decided to have this research approach to ensure quality implementations and generate useful learning. Next. At the start, to understand the working environment better, we did a capacity assessment of selection of health facilities and pilot and policy analysis, while we used various guidelines and programs in South Sudan that address the child health and nutrition that also include infants under 6 months. For examples of the key guidelines are shown on the screen. Here, and many address certain aspects of nutrition and health of infants. And then, while we are introducing MAMI care pathway, we always get discussions of introducing the MAMI care pathway, whereby you will hear many people are saying, we are already doing this activity, we are already doing this in our policies. And indeed, it might be so, but better targeting the risk infants and their mothers. The ADAPT MAMI care pathway for South Sudan will address what need to be strengthened more and gap that may be filled or will do better. The South Sudan government and partners are therefore eager to learn from the pilot study and decide to improve specific guidelines and adapt strategies or programs to improve infants' outcome. Next. We opted for a collaborative participatory approach for adapting and implementing the MAMI care pathway in which is this very new in the South Sudan context and other implementing partners except UNICEF and WHO. And therefore, the start of operation research has taken longer than initially expected. We share our plans today. We hope we need to have another chance of webinar once the operation research is completed to share our lessons learned. The full timelines of the pilot study cover at least 6 months of preparations, 12 months of implementations, and 6 months for data analysis and documentations of the lessons learned. In the preparatory phase, we started with many participatory and consultative meetings with the Ministry of Health, WHO, UNICEF, and other implementing partners, introducing MAMI care pathway version 3 into South Sudan context, until we reach an agreement to do the pilot study and submit for ethical review approval. Next week, after getting our approval, next week we'll be having our national level stakeholder meetings, and then the sub-national level orientations and trainings that is clearing our flow to start our pilot study. Next. By the end of July, we'll start enrolling mothers' infants' diets into pilot study, and to take place of another 12 months. Next. After the implementation, we'll have data analyzed, findings documented, and lessons consolidated, and the recommendation for the South Sudan Ministry of Health formulated. Next. In this slide, we'll be looking at the partnership. This endorses us. In this slide, it will give us where are we going to implement our MAMI care pathway. So our MAMI care pathway will be implemented in 5 sites in the 3 regions of South Sudan that correspond to 5 primary health care centers, communities in the catchment areas, and referrals to the hospitals. Referral hospitals are involved because first, they will be accepting the referrals of infants, mothers, dads at high risk and will severely, those are who are having severe conditions, including maternal mental health and support. Secondly, we need the hospitals need to update the malnutrition treatment protocols since uncomplicated severely wasted infants under 6 months will be enrolled and treated as outpatients according to the MAMI care pathway protocols. Next slide. The piloting study populations are all infants under 6 months and their mothers in the catchment area of the 5 sites, who will be actively screened in the community and or routinely screened in the health facilities. Targeting infants under 6 months, those who are at moderate risk will be enrolled. Infants, mothers, dads at high risk, they will be referred to inpatient care. And infants, mothers, dads at low risk, they will be continued in follow-up in the preventive community care activities. We expected to target 500 mothers, infants, dads across the 5 states over the 12 months. In case of any sample size is necessary to be increased, we will enroll more infants, mothers, dads to make up the loss and or expand the timeline. Next. The criteria, here we'll be looking at the Intrigue Criteria for enrollment. Intrigue Criteria consider both infants under 6 months and mothers. For infants, conditions are low birth weight, underweight, wasting, gross filtering, and any care or feeding problems or other risk factors that put the health and development of infants at risk. For the mother or the caretaker of the infants under 6 months will be targeted, and independently enrollment criteria can be any problem that impair her well-being, whether it is nutrition or health-related problems, including mental health and social support. The infants and mother exit the MAMI care pathway when the infants reach 6 months and depending on their health and nutrition status and referral for the follow-up services. Next. The data tools that mirror CMAM, which is Community Management of Acute Malnutrition data tools, as they are not unknown by the healthcare workers, and their adaptation will be discussed during our upcoming stakeholder meetings by next week. Example of the data tools that we'll be using during the pilot study will be registers, tally sheets, assessment forms, reporting forms, and digital database. Moreover, we'll explore the use of digital tools, for example, the exploring of expanded WFP, WFP scope coder applications. Next. We plan to continue learning and adapting during the study by monitoring the care pathway implementations for continuous quality improvements without loss of any comparability of data, exploring accessibility and feasibility of integrating the MAMI care pathway and make adjustments as needed, linking the MAMI technical advisory group and the technical implementary group and collaborate with the reliable working groups and global network groups that generate information and adapt and updating national health and nutrition policies. Next slide, and this is going to be my last slide. While we are having not yet starting our implementations, but we still have some lessons learned, good lessons learned up to date. By the lessons learned, engaging the Ministry of Health, partners, and early promoting participatory learning and ownership. Also, early onward that make us to expecting the study protocols. For example, one suggestions of improving representativeness of the country context. We are able to exchange one of the selection sites and include one state, Jungle State, to make a representative of some of the contexts in South Sudan. Familiarizing the piloting study with the ethical review board of approval, starting eager of operation research and learning for future decision-making and scaling up. Finding are not generalizable, but learning will be transferable to other sites. Involving in national and global learning network contribute to the learning from other contexts. And now I'll hand over to Kirk to summarize the global learning. Thank you.
Great. Thank you, Mary and Hedwig, for the excellent and very comprehensive presentations. We'd now like to turn a bit to learning and adapting for other contexts. And we hope that what we have presented and what we will now present, along with the work of a number of other organizations and individuals, will be helpful as you think about using the care pathway, adapting it in your relevant context. So some of the things we've learned include the following. One of the things we did at the very beginning was to carry out a policy analysis to contextualize our work within the various policies that Mary mentioned within the Ministry of Health. And we feel really strongly that that needs to happen at the beginning of any adaptation of the care pathway, regardless of which country you may be working in. We also feel that the care pathway adaptation should be built upon existing structures and address any gaps, both in terms of policy and implementation of those policies. One of the things we also feel quite strongly about is it's important to document the actual process, the whole process of the care pathway adaptation from the start to the end. And we feel that this isn't being done enough globally, so we hope we can contribute to that work. Through operations research, we hope to maximize learning about the care pathway adaptation, and then to disseminate results in a variety of settings, which I'll talk about in a minute. And we look forward to working with all stakeholders as we collectively formulate recommendations. So there have been a few challenges that we would like to talk about. First of all, involving multiple stakeholders required quite a bit of time and coordination, more than we expected. Hence some of the delay in carrying out the adaptation. We also sensed the need to orient a variety of individuals to MAMI and the care pathway because they weren't necessarily familiar with it or clear about the rationale for integrating the care pathway into their work. So that took longer than expected, but we feel strongly that that extra work really paid off, and we have broad buy-in from government and other implementing partners. And finally, working in fragile settings brings its own unique challenges. For example, in selecting the sites where we are proposing to do the adaptation and study. Sorry, I didn't forward on to the next slide. Can you go on to the next slide? Okay, and the following one. So in terms of opportunities, we see that there are a number of opportunities that are coming forth from this work. And one of those is working with the South Sudan government to review and update national health and nutrition policies based on our findings for operations research. The new policy will come out in 2025. And then scaling up the MAMI care pathway using successful findings and experiences and in South Sudan and other settings is really critical. I should mention that we're now planning to adapt the care pathway in Mali as well. So we're interested in hearing, learning from those experiences. We're also excited about the opportunity to learn more about maternal mental health interventions and to inform those through our adaptation. And we, as a result of the operations research and other experiences, we are looking forward to suggesting some specific questions that might be pursued in future research. And as Hedwig mentions, we are going to disseminate our experiences and research findings broadly, including with the MAMI Global Network and the Emergency Nutrition Network, as well as all of you and others on this call and elsewhere. Next slide, please. So we'd like to take a moment to thank you for joining us. And at this point, I think we'll go ahead and move into our discussion in the time remaining. So I see that there have been a number of comments in the chat, as well as perhaps other comments and questions that you may have. So maybe let's start off with the comments in the chat. Let's see, let me find the first one. Okay, so scrolling back through, there was one from Male about the 1,000-day window of opportunity. Just a clarifying question from Male, you mentioned that the weaning period is at around 6 months. Did you mean 6 months or did you mean later than that, you know, the first year or two of life?
And Kirk, I would just note that if people, we have actually plenty of time for our discussion. We're actually a good disciplined group, so we're way ahead of schedule. If people wish to pose their question orally, you can raise your hand and then Kirk will recognize you and ask the interpreters to bring you off of mute. So that you can either write in the chat now or pose your question orally by raising your hand. And then if we can move to the next 2 slides, just advance the slides to the end, to our last slide. And we will also be doing, we'll be posting in a few minutes, we'll be posting a link to a feedback form. If you could fill that in, that would be a great help to all of us. So let's go to the last slide, and sorry to interrupt Kirk, but let's go back to your question with Molly. Thank you.
Okay. While we're waiting to hear about that, maybe we can ask either Hedwig or Mary to respond to this. So I'll assume for a moment that we're talking about the period right around 6 months, which is particularly problematic with the introduction of complementary foods, often at an age that's too young. So Male's question is, how will the MAMI care pathway ensure continuity of care for infants really from 6 months to the closeout of 2 years of life and beyond? So Mary or Hedwig?
Shall I go for it? So Male, maybe you remember the slide when I talked about the care pathway, that at the end, at reaching 6 months, we re-evaluate the mother-infant diet, so both of them, and see if they need further care, if they are still vulnerable, and then certainly strengthen the links to continued care, whether that is just supportive or if this is still a curative care that they would need, hopefully not after they have been 6 months under good MAMI care. But this is definitely a point that MAMI makes, that it's not just stopping at 6 months, it's really making sure that things continue tailored to the need of the infant and mother. So if that answers your question, so it's for community at a community level, and I think MAMI has really that vision as well, to make sure that these linkages, not only the linkages for referral, but also that the services of referral are up to the level that is needed. Maybe Mary, if you want to add, please do. If not,
Go ahead, Terry, back to you.
Sure, yeah, Kirk, yeah, go ahead, Mary.
Mary, did you have a comment about that question? Maybe we've lost her. Or she's
Check,
on mute.
check the mic. Maybe it's mute, Mary.
Mali, do you think we have answered your question? Do you expect more specification? Because basically, I think I said what had to be said.
Maybe while we're waiting for, we'll go on to the next question. This one's from Marie, and she has a question about study population and active screening of children under 6 months of age, and wanted to know whether this is going to be done by CHWs through routine operations research activities. Will there be a mass screening? Will there be the use of family mid-upper arm circumference or some other strategy?
Mary, if you're not available, shall I go for it? Mary?
Yes, by all means, go ahead.
Okay, sorry for that, to take over. So in South Sudan, we have a community, a BOMA community health initiative, and they have community health workers called BOMA health workers that we certainly want to train and to use. Now, we will also in our coming days we will have a 2-day stakeholder meeting that will be followed by a 2-day implementation training, targeting different audiences. The first 2 days is more at a national senior level, while the next 2 are really the implementers from the sites of our pilot. And so we will discuss together with them what is the most appropriate way to go forward to. And I don't think that mass screening, well, if the opportunity would be there, it could be considered, but it's really, we really envision to integrate the MAMI care pathway as something that could be sustainable, building upon what is existing and further strengthening that, but not having, let's say, separate structures in place. Having said that, so we will further discuss that with the people involved of what they think is the most appropriate thing for their context. Now, about the Family Mooc, that's a very interesting question, and that again, I think we will have to see. But here we have to consider that in the community, definitely we will use MOOC to identify the infants under 6 months. This is based on evidence, but we are still waiting for WHO new guidelines to see if this can be like a formally recommended indicator to use. But nevertheless, for research purposes, we will use MOOC in that age group of below 6 months, because it is too good of a tool to identify early these infants. And now we have an adapted MOOC tape that some smart people from the network, from the MAMI network, have developed. I think Gol was a lead in participation with others. And we have received this just recently. So we will use these MOOC tapes. And they are maybe a little bit difficult to be used. And this is also part of I have one here. Maybe I can quickly show one when I'm talking, because it's a bit different from what we are used to. I'm making too much noise now. Look, it is like a very long one, and on one side it is for the mother, the other side is for the infant, and this may be a bit tricky to see that we. Maybe it's a bit too early to think about giving a MOOC tape to the mother and to monitor the infant that is already like a difficult age group. So, but these are all things that we will consider and we will think about and maybe test in a small group and see what learning we can do from that. Over.
I don't know whether Mary is available.
Yeah.
Okay.
Yeah,
Did you
sorry,
have anything else?
Yeah, for Ivita questions about what will happen for under 6 months screened at risk, but the mothers are not there. Still, if we classify that according to the criteria of Intrigue Criteria for under 6, if they fall under the criteria, yes, we will enroll them. Although the mother, because some of them might not have their mothers, but we'll enroll the caretaker who is taking care of them to know exactly what has happened. And it will depend on the enrollment criteria, whether it is a high risk child with a severe malnutrition that will need referral, or it is a moderate risk that will be enrolled, or it is a low risk that will be able to manage at the health facility or at the community through the management protocol of MAMI care pathway. Thank you. If Hedwig want to add something, she can add.
I think
Sorry, I have nothing else to add. There are, Gabrielle had a question about the objectives of the research. So I've pasted those in the chat. Maybe I won't go over those in detail because there are quite a few. There's a question in French from Zaku. Perhaps our translator can let everybody know what that is.
Et voilà, Dani, tu peux s'il te plaît la dire, je t'écoute. Dani?
Otherwise, I can quickly say what it is about.
Oh. Let me check
Sure.
it. Let me quickly.
So it is about the question is if there is a gap in the national protocol for the.
Pregunté sobre el protocolo internacional de la gestión en Sudán del Sur, pensando que, digamos, en Sudán del Sur y
the national protocol and to integrate MAMI. So that is our wish, of course, Zaku, that we, at the end of our pilot, we will be in a good position to discuss about the adaptation to adopt MAMI and integrate it into routine mother and child health and nutrition services, and have that protocol adapted. Now they have already a plan. South Sudan has a plan to revise the guidelines in 2025. But maybe you're also knowing that at the moment WHO is revising the evidence to update the guidelines like they did in 2013. So I think by the end, I'm part of that expert team, and I think if we are lucky, by the end of this year, we will have these recommendations available, and these are recommendations answering 23 detailed questions. Also, of course, not only the under 6, but the under 6 has quite some questions addressed, so it's quite interesting for us to learn from. And it may be that with having these recommendations available, that some of the national protocols revisions may be accelerated, because I also know that WHO is working then next on a generic operational guidelines, and also has money available to then help governments to update their protocols. But this is, of course, what we would like to see happen as soon as we have a good understanding of how important MAMI is for the context of the country. Over.
Did we answer that question in French? Is it all right? Otherwise, we'll do it again. Zaku Yayala has a question in French. Is that the one, or that's another one, Terry?
Yes, she answered. So hopefully the interpreters translated into French her comment.
Yeah, we got it.
She-
We
yeah,
got it.
yeah,
I just
great.
want to make
Okay.
sure that that's the question we're talking
Yep.
about, or whether there's another one.
We should be good. Thanks.
There's a question specifically for Mary about what happens in a situation where you have an under 6 month child who's screened and at risk, but the mother is not. Are they excluded or referred to the primary healthcare center or hospital?
Who's going to answer this one?
Mary, I think that was a question for you. If you want to come off mute and or turn on your video.
Otherwise I can answer this one.
Yes, go ahead. Hedwig, go ahead.
It's on her session. So the question is, what happens when the under 6 months are screened at risk, but not the mother? So no, definitely so. If the infant is at risk, this is either or, definitely so. Then we will the infant will be enrolled. It's not that we have to have end risk factors with the one and with the other. I think one risk factor is enough to be considered. And of course, if, like, for instance, there is discrepancy between the status of the under 6 months and the mother, I think the worst condition, that is where the couple or the pair will be referred to. I think that answers the question. Yvette, is that clear?
I believe so. Very clear. Next, Terry.
So there's a question from Zaku about children who are older than 6 months of age, but under 3 kilograms. And he mentions that in the Niger protocol, recommendation is to have, is to similarly consider these individuals who might be older than 6 months, but under 3 kg. I'll answer one part of the question, and that is, for our study, we're only focusing on children less than 6 months of age. Hedwig or Mary, do you want to talk about MAMI more broadly? As far as I know, there's no guidance for children greater than 6 months of age, but I could be wrong.
No, thank you, Zaku. This is a very pertinent question. First of all, I must say that infants above 6 months under 3 kilos, WHO is not like considering them different. We really target the +6 months. And in that case, this is an inpatient care child, according to, because it's a complication, the very severe and underweight condition of the child. So this will be, let's say, this will be covered by operational guidance, and the evidence or the recommendation from the WHO is that if it is a medical condition that requires inpatient care, that person goes to inpatient care. And this was matching before with the under 6 months, because they were already all referred to inpatient care. But now I think MAMI will not consider these, because this is a different age group and needs a different attention. Is this okay? Is this clear? I think in the future we will stick more clear with the age group. Okay, there will always be flexibility, probably, likely, but the guidelines, operational guidelines, will make a difference between the under 6 months and above 6 months. But again, equally, if they need inpatient care, they will go to inpatient care. If they are at high risk, they will go to inpatient care. And an infant above 6 months that is so small is definitely a medical complication. So there should not be any worry.
Okay, there's a question from David Mbugua about MOAC, the use of MOAC screening for active case finding. Of course, that's what's used under CMAM, community level. Do we intend to use the same for MAMI, or are we also using other criteria?
Again, I think this is a very good question, and I do not have the definite final answer for that. And this will depend on how the people, the responsible people of the government in South Sudan have considered the BOMA health initiative. What is their skill level and what is possible. I think for active community screening, the MOAC tape or the MOAC measurement is like a straightforward thing to do. And in the past, through community IMCI or growth monitoring. There was, of course, or there is, of course, within MIYCN, when you detect issues of growth faltering or problems with breastfeeding, the infant is referred, and that will not be altered, of course. So we will look at these elements and take them on and make sure that we build upon these. So if they are not existing, we will consider. If they are existing, we will use them. So not to confuse matters in the community, and with as aim to have as many infants at risk identified and taken care of. Over.
Looks like Ade Baba has a very similar question. If you could let us know in the chat if we've answered your question, that would be great. So there's a question from Yvette about the tools and whether they will be translated into French. Of course, that's one of the major ideas for our work in Mali. Yes, these tools will be translated into French, which will be helpful for the MAMI Global Network overall. And that will be part of our work in Mali. So there's another question from Gabrielle about primary objectives and avoiding death and wasting. Are we planning to use a control group? So Hedwig or Mary, would you like to answer that? I will say that you know, for some of these outcomes, we're statistically underpowered, but that's something we recognize.
That is definitely so, and as well as our study is considered a pilot study, it's a longitudinal following a cohort of children. We will not have a control group. It's not an RCT, so other studies will look at that. I mean, not us in South Sudan, but there are other studies ongoing who do that.
So I'm not seeing any other questions in the chat. If you have another question, feel free to either put it in the chat or raise your hand and we can answer it.
And a quick question out to Chris Lindahl, who's also monitoring. Chris, have you seen any questions that have come through that we may have missed, or have that pretty much gotten it? Thanks.
No, I think we've gotten them all.
Any other last questions from anyone?
Am I allowed to ask a question to somebody from the audience?
Absolutely. Go ahead.
So I can see that Hattie is following through, what is it? Through Mary, well, through somebody else's computer. So Hattie, if you hear me, her name is Marie Halise. So if you have to unmute her later. Hattie, if you are still there, I think it would be interesting to hear from you if you have been thinking about using this adapted MAMI Mooc tape for use on Family Mooc in the community, or if you have anything related to this community screening that through your experience is already like interesting for us to hear. Over.
So that would be for the interpreters, if she is willing to speak. It's under user or attendee Mary Halise. So if you could unmute Marie Halise, that would be great.
Cami, desmuteala a Mary Halise. Mary, go ahead and put the hand, put your hand, raise your hand. That way we can spot you really quickly in the gallery, because there's like 45 people. So to pick you right away, you raise your hand. You'll be coming up first. And you raise your hand, Mary. Tu peux choisir la main. Tu parles français ou anglais? Tu peux choisir la main. You can choose the hand and raise it. Camilo, ¿tú la ves? para que habilites el micrófono de Marie.
Hedwig, I'm off mute. Can you hear me?
And now we
We
can
got
hear
you. We got
Yeah.
you. Excellent.
Hi.
Go ahead.
Sorry, I joined Marie's link. That's why I'm coming up as her. Yeah, so to answer your question, yes, so we've been using what Goal have been calling the MAMI MUAC, which is similar, a little bit similar to the MUAC that you showed earlier. So that's what we're calling the multi MUAC, and that's what's been designed in collaboration with ENN, UNICEF, and WHO. So it's similar to that. It's not quite as long, but it was based, I mean, largely the design sort of worked off the MAMI MUAC, and then we sort of looked at what wasn't working, issues with MUAC tapes more broadly, and came up with that design that you're holding in your hand at the moment. So the MAMI MUAC we've been using in Gambella, and we've been using it through the Family MUAC approach as well. And in 2019, I think we did an assessment. So I think there were over 3,000 families trained on the use of the MAMI MUAC. And we found broadly very, very similar results that we would find with normal the regular 6 to 59 months and PLW MUAC tapes, in terms of, I can't remember off the top of my head, but it was around 78 to around 81% sensitivity. It was broadly exactly what we saw in terms of sensitivity and specificity that we saw with a community health worker case identification. So there was no significant difference in terms of the family's ability to use these tapes, which included the additional identification of infants under 6 months. So it included 6 to 59 months as usual. It included the PLWs, and we obviously included the 2 cutoffs for infants under 6 months, which are the same cutoffs that were presented earlier. So we found that it has been, people have been able to use it. They've been able to use it with a high degree of sensitivity and specificity. What we're now planning on using is the same research that you're part of, hence you've got those tapes, is looking at this multi-MUAC, and we're looking at a few more indicators, a bit more data, just in terms of trying to understand the utility of them, how well they are understood, whether people are able to use them accurately, and whether they would make any changes, whether there would be any feedback from the community and from the families themselves in terms of any changes to the tapes to make them more practically applicable or better understood. So yeah, in short, I'd say we have used them, we've used them well. There have been no issues. The only problem, if you like, with the use of MAMI tapes at the moment is just because we still haven't got any internationally recognized guidelines other than what UNICEF and in collaboration with other UN agencies released during COVID, which was the use of MUACs for infants under 6 months, less than 11.5. So yeah, that's where we are.
Edward, did you have a comment? Looks like you're on mute.
No, thank you. It was interesting to hear, and this is definitely work in progress, and we will further talk about this issue, I think, but that's exciting.
Deme had a comment. I'm not a French speaker, but it looks like there was appreciation for the availability of documents in French. And those will be translated once we have a little bit more experience in South Sudan. Hedwig, do you have an estimated timeline for getting those documents in French?
Actually, Tabitha is also following, I have seen earlier, and she is based in Senegal doing research, and we have already talked and linked and seen how we can collaborate on these translations, but she's already ahead of it. So maybe Tabitha, if you're still here, you can say something of how it goes. By all means, the MAMI global network exists, and you're welcome to join that group. It's an open group, and we share all resources online available for everybody. So whenever there is something available for use, you will find it on the ENN website. So that I can already say. But Tabitha, are you still there?
Hedwig, I do not see that name on the attendee list right now.
Okay, then maybe she has left. But anyway, so keep an eye on the ENN website, on the MAMI page, and you will find it as soon as something is available. But we will systematically work together as a group to refine that. Just knowing that maybe the generic materials, I think the generic materials will be made available, and then we will of course adapt these to the country contexts we will be working. So this work in progress. But you can always welcome to reach out if you need some of the documents. We can already informally share when we are happy enough with the quality of the translation. We definitely can already help each other.
It looks like maybe it was Hattie who just posted. Let's see if I can get to it. Right.
Yeah, sorry, I didn't put the link to ENN.
Hedwig. Hattie, some resources that are available based on Goal's experience in Ethiopia.
Yeah, it's just a link to an ENN article that was published last year, just on the use of the MAMI MUAC tape. So you can see the operational research we did and the results that we had through that ENN link.
Great, and I'll just put in a quick plug for the field exchange from the Emergency Nutrition Network. Excellent resource, really very practical and always fun and enlightening to read. Terry, perhaps over to you.
Yes, if anybody else has any questions, just please again put them in the chat or raise your hand. Otherwise, I would just again ask you to consider scrolling up in the chat and finding the link to the evaluation. That's really helps us as we go forward in future webinars to take your comments and recommendations into consideration of how we do this. Otherwise, I would just ask maybe the interpreters to leave not to close our meeting for about a minute in case people do want to click on that link. And then once they're on the link, we can close out. But if there's no more questions, I want to thank our panelists. Thanks, George, for the introduction at the beginning. Thought it was a very interesting conversation. Thanks to Chris and everybody else working in the background to keep us moving along and for posting all the valuable links. And I see Chris posted the link one more time there for the evaluation. So please do that. Thank you all for your attendance. And for the transit, I would say, let it go for about 30 more seconds and then we can turn the meeting off. This, as I mentioned earlier, this will be posted on the Momentum website as well within the next couple of weeks. So thanks, everybody. Have a great day.
We'll leave the meeting on until you let us, until you tell us. We'll leave it on. Bye-bye, everybody.
Thank you, everyone.
Thanks, everyone.
Thank you.
Bye-bye.
Thank you.
Bye, everybody.
Yeah.
À tout à l'heure.